to kind of keep discussing. Next slide, please. Oops. I got my notes here to keep me on track. So if we look statewide, about 17% of Mainers are smoking. However, this percentage varies from county to county, with rural areas showing significantly higher rates than the counties along the East Coast and southern Maine. So this is the unique challenge of tobacco in Maine. For these bigger questions that we are asking all the time at CTI is, how do we reach the individuals who live in these rural communities? How do we bring access to evidence-based treatment to these folks? And we feel like lung cancer screening is a new and exciting opportunity to do just this. Slide, please. With no surprise, we see the impact that the intersection of virality and smoking has on cancer mortality. So this analysis showed strong correlations were observed between regional prevalence of smoking, poverty, low education, and lung cancer mortality. And thus, we see the importance of addressing smoking as a crucial part of the mission to prevent lung cancer. Next slide, please. The LDCT screening process is an ideal opportunity to provide tobacco treatment interventions not just once, but at several points. The more the interventions are offered, the more motivated a person becomes. And even at baseline, the U.S. National Lung Cancer Screening Trial showed that 87% of patients reported an interest in quitting. Delivering a caring and compassionate message about the availability of effective tobacco treatment at every patient encounter increases the chances of a patient deciding to quit and also enhances their overall quit success. Research shows that most smokers want to quit, but many just are not ready. And the leading factor for why they're not ready is they don't know how to quit. So there's an issue of sort of confidence, low self-efficacy, low belief in their ability to quit, low access to evidence-based treatment. So having regular, non-judgmental conversations with patients in which you discuss the fact that we can help you when you're ready enhances a patient's confidence, makes it more likely they'll accept your offer of treatment at one of your interventions. So one of the things I'm going to bring up kind of repetitively here is that wanting you to think long game. When we're talking about addiction, in this case tobacco addiction, it's not that at one given moment in time we have to motivate that person, get them to accept a medication or make a quit attempt, but it's sort of through this repeated touch over time where we come at them from a place of compassion, genuine interest in understanding their story, their smoking experience, that we walk along their journey as they get more and more motivated, and then we're ready and available to them when they are ready. So in thinking about lung cancer screening, an invitation to all of you to think about these three major opportunities. So the pre-screen period, so when you're identifying the high-risk smokers engaged in shared decision-making visit, this is a great opportunity to address tobacco. And then invitation to think about how can your program do this at the actual LDCT screening visit itself, and then in the post-LDCT visit, what's another touch? How do we, in that interaction, bring up tobacco in some way? And so we want to invite you guys to think sort of creatively about how we can do this better. Okay. As I'm sure you are all intimately familiar, the billing requirements from CMS include tobacco counseling, which we're glad for, both at the initial LDCT visit and at the radiology imaging facility. And I think the challenge before all of us collectively here is to not simply meet the requirement, but to take this as an opportunity to engage in a high-quality, evidence-based interventions that we have the biggest impact on these patients and these communities. Oh, I forgot, this is a slide with some action. Okay, you can just pop all of the statements up there. Didn't think that part through. So a couple of myths that we often talk about when CTI is out doing training, trying to bust some myths for you guys. So first, that patients don't want to quit. I think it's easy to get that belief as a provider when you are engaging with patients and asking them about their tobacco use and hearing a lot of no. But the reality, the data shows that about 70% of tobacco users would like to quit. So again, it's not that they aren't interested in quitting, it's usually something deeper, so lack of confidence, lack of confidence, lack of access to treatment, things like that. Patients will resent being asked. That's something we hear from providers. I've already asked them. I asked them last year, when actually the data again shows that patients report greater satisfaction with providers who address the behavioral health issues. They're sort of expecting us to ask about these things, and when we do that in a thoughtful, caring, compassionate way, they end up feeling cared for. And it's too time consuming. And again, we'd like to argue that even a minimal intervention lasting 3 minutes or less will increase overall tobacco abstinence rates. So it's that long game again, thinking I don't have to get the person to quit today, but can I make it safe for them to talk to me about their tobacco use so that the next time I am with them, the conversation gets deeper, and the next time I interact with them, the conversation gets deeper, or they go to their primary care who continues the conversation, and if they feel safe and supported, that they're more likely to move towards quitting. Ready for the next one? And what we say here is your approach really matters. So this is a population of people that's been stigmatized, that tends to feel a lot of guilt and shame. You know, folks know tobacco use is bad for them, and here they are still doing it. In this particular population, they've been doing it, often 30 years or more. Many of them have probably tried to quit before and haven't, and so it's really common that there becomes sort of an internal self-narrative about being a failure, not strong enough, feeling a hopelessness about being able to do this. And so, one of the things we would really argue is that our approach really matters a lot. And so we think about the outcome of an effective intervention being that the patient feels supported, understood, not judged. So again, not that they've quit or committed to quitting, but that they feel safe in the interaction and are willing to keep having the conversation with us. And we would argue that you accomplish this by engaging the patient on a level of compassion and empathy, understanding that they have a chronic relapsing addiction. It's not a character flaw. It's not a lack of willpower, which is some of the implicit messaging they've been sort of given through their life as a smoker. Creating a safe place for patients, supporting and encouraging them at every opportunity. They will respond, and it's our job to hang in there with them. Next slide. So an evidence-based brief intervention model you maybe have heard of before is the 5 A's. The ask about tobacco use every time, advise on quitting, assess the interest in quitting, assist by offering help when ready, and arranging follow-up. This is something you can see more about in the Public Health Service Guidelines, which the citations at the bottom there. And these strategies are really designed for kind of healthcare and designed to be brief and requiring less than 3 minutes of your time. They're also not meant to be done in the invitation is to be flexible with them. So one thing we see in primary care now is that we're often encouraging the MA to be sort of the one who's asking about quitting, perhaps teeing up a referral, but then the provider is the one who sort of really advises on quitting and certainly does assisting with medication access. So it can be more than one healthcare professional can team up to complete the 5 A's. It also doesn't necessarily have to go in this order. So there may be a clinical setting or maybe just with a certain person that you're with where it feels more appropriate to assess their interest in quitting before you advise them to quit. So this doesn't have to be rigid. Okay, next slide, please. We do encourage it to be personal and to be compassionate. So, things like making it personalized, one of the best things you can do to reduce your risk of lung cancer and to improve your overall health is to quit smoking. Making it compassionate. I understand it can be hard to quit. I think patients need to hear that from us. But I'm concerned for your health and help if you are ready to try. I think the more we can signal to them that we understand or we're trying to understand, we're interested to understand that this is really hard for them, the more they're going to open up towards us. Next slide. The other thing that is becoming more and more common and supported in the literature is sort of an even more brief model than the 5 A's. So data suggests that ask and advise are sort of generally utilized, where the last 3 A's, assess, assist, and arrange, are a bit underutilized, but assist is more effective than advise. And so there's been a push in the literature to kind of even shorten this more and figure out how do we get assist to be more in the mix. So one of the things we talk about here a lot is, can it be ask, advise, refer, ask, advise, connect to treatment, ask, advise, offer a script depending on your clinical setting. But that challenging you guys all, or I'm interested to have a conversation with you all about what can assist look like in this context with these patients. Next slide, please. One of the things I would argue is that this is a real great opportunity to get patients connected to the Maine Tobacco Helpline. So just briefly, a little bit of information on the Maine Tobacco Helpline. If anyone's interested, I can certainly give more depth information at another time, but it's a free service available to all Maine residents. It's a flexible call program. We do outgoing calls, so we will make up to 4 outgoing calls to anybody, and then individuals are welcome to call in as much as they'd like for additional support. It's free, it's confidential, the staff here is very well trained, and it's a great way to think about reaching some of the folks who live in these rural places and may not be able to drive to an appointment. That may not be feasible for a lot of people. So the one other thing I was going to say is about the medication program. So folks are also eligible for up to 8 weeks of nicotine replacement therapy free through the Maine Tobacco Helpline. And for those who are eligible based on their tobacco use, they can get combo NRT, so patchless gum or patchless lozenge. The only kind of tricky exception here is for Maine Care, and without getting into the details, essentially at sort of the funding state level, it's considered double dipping for our statewide program to give out NRT to this population, Maine Care folks, because they have a really comprehensive benefit through Maine Care. So it's already kind of coming through the same dollars, so to speak. But Maine Care actually has a better benefit. It's like essentially unlimited NRT, or maybe not quite unlimited, but it's really great, plus the prescription medications. So if you are working with someone who's a Maine Care folk, they could still do the counseling with us, and plenty do, but they would need to get their meds from through prescription through their insurance. The helpline is effective, so this may not be a surprise, but still the #1 quit method out there is cold turkey. That's still how most people do it. And I think that's partly from that narrative that's out there that you should be kind of strong enough and use your willpower. And this is not about willpower, it's an addiction. So the cold turkey method is about a 3% success rate. Sometimes you see 4%, 5%. So not very successful. And the Maine Tobacco Helpline has much better quit success. So the overall quit rate is 26.1% when people really stick with the program. So completing 3 or 4 calls, that climbs up to 36.3%. This is something we're really proud of, and which is why we would love to have conversations about how we can get folks who are lung cancer screening patients connected to our service. This data is based on a 7-month outcome survey that we do every couple of years. Thank you, I'm getting my 1 more minute. Okay, that's good, I'm ready for the next slide. So the last couple slides here are just sort of teeing up, hopefully, our discussion for later today, or discussions that you can kind of take back to your programs, but sort of thinking about those 3 opportunities: shared decision-making, kind of the pre-LDCT scan period. If you're a primary care focused program, how can your program partner with the primary care practice around you to sort of think about who's doing this, who's owning the tobacco piece, and who's doing that well in shared decision making. If you're a centralized program in the hospital setting, what does that look like? Who's asking, who's advising, who's assessing, et cetera. Next slide, please. At the LDCT scan visit itself, I think I've already kind of said this enough, but one thing we would really encourage is this proactive referral to the Maine Tobacco Helpline. If you refer to us, we will then call out to the patient. That's a lot more effective in getting them hooked to treatment than simply giving the self-help material or brochure, because that leaves the person who's maybe got a lot of feelings about what's going on in the driver's seat, and when we make that outreach to them, they're more likely to get treated. Another thing I just wanted to bring up, is just the idea of pre-quit NRT. So just in general, research has continued to develop on NRT. It has a really strong safety profile in general. And now they've begun looking at pre-quit NRT. So this idea of starting your nicotine replacement therapy prior to quitting. And we actually see higher quit rates, and it's really continues to be safe. Basically, smoking gets less satisfying. It allows for early practice, early changes in your behavior. It also might shift attitudes. Maybe someone starts to begin to feel a little more confident and motivated. So that's another thing to be thinking about. Next slide, please. And then just again, in the post-scan process, how do you communicate the results of the scan, and where in a conversation does this fit? What materials might you include with a letter? Same thing when they're coming back for their annual scan. Maybe this is the year they are willing to talk about it, or better yet, willing to make a quit attempt. We believe in all tobacco users' ability to quit when they are ready. We want to treat them that way. So the last slide is just kind of a kickoff for our discussion later today, and again back home. If we keep thinking about that long game, how can lung cancer screening kind of contribute to the long game in a tobacco user's life, moving them closer to quitting, closer to trying to quit, closer to quitting. I look forward to talking about that with all of you. Thank you.
Excellent, Catherine. Thank you so much. That was awesome. I know it's